Trail Guide, 6th edition, Chapter 2 is covering the shoulder and the arm. Each chapter I will go through the same way. We will start with the bones, the bony landmarks. We'll go to the structures that are on top of the bones. Then we'll go through each muscle of the chapter, and we'll end with the action breakdown of all of those muscles. Please know that although this recording will be over an hour, you can pause and take a break. Just write down where you were when you did that pause, and then you can always go back and then carry on. I don't expect you to sit and do this all the way through in one shot. On page 46 is an overview of all of the areas that you ought to be able to identify by time you get done with this chapter. This is also in your workbook for you to do, and I would strongly encourage it when you are done with the chapter. As far as what's on page 47, if you have done any manual therapy on perhaps yourself or someone in your family or friends, you've probably done those things, but I do encourage you to do those same things that they're showing there on those areas. So now you're going to look at them from a different aspect. Page 48 at the top is where we'll begin to just start this process. I know that for the purpose of this video, I can't get the entire page on there, but that's okay. Let's focus on the paragraphs at the top, and then we'll look at the pictures on the bottom. This chapter is talking about 3 bones that are making up the entire shoulder complex. We have the clavicle, the humerus, and the scapula. So we have our collarbone, clavicle, the humerus, our upper arm bone, and the scapula, which you will come to learn is also on the front of our body, as well as the back, even though we think of our shoulder blade as always being in the back. Next in the paragraph, I have that the clavicle articulates with the acromion of the scapula to create the acromioclavicular joint. So here we have that. So it's more towards your shoulder on the outside, and it's just where the clavicle and the acromion point come together. The sternoclavicular joint is the next one. So it is where the sternum meets the clavicle. I have also that these are both synovial joints. That's what we talked about in chapter 1 on page 34. You can go back and look at those. And I also want you to make sure that you have that the sternoclavicular joint is the attachment site, or the area between the upper appendicular and the axioskeleton, which again you can review on pages 32 and 33. When we talk about the scapula itself, also known as the shoulder blade, I want you to remember that the scapula glides across the posterior surface of the thorax, or the back of our rib cage, and that is what creates that scapulothoracic joint, where the ribs meet the scapula. The other bone is our humerus, or our upper arm bone. The proximal humerus articulates with the glenoid fossa, and that creates the glenohumeral joint. So where the head of the humerus comes into and meets up with the scapula. The glenohumeral joint is also a synovial joint, which again, you can look at page 34 for that, but it is a ball and socket joint, which means it's capable of a wide variety of movements and in all different planes. At the very bottom, that box on the bottom, just an interesting and something that we want to keep in mind as manual therapists, that the clavicle is the first bone that starts to harden when we are in utero, but it is the last bone that will be fully developed, which then leads us to having it be the most frequently broken bone in our body. And that SC and AC joint is where dislocations can occur quite often. For what we have on page 49, I'm going to come back to, because I want to look specifically, I want to start with the easier bones, which is on page 50. We're going to start just defining the clavicle, or the different points on the clavicle, because that's the easiest. So I want you to palpate these on yourself as we go through this. The acromial end is towards your shoulder. The sternal end is towards your sternum. And then notice that the clavicle has this S shape. I want you to palpate that on yourself and be able to know where that happens. It will be important when we talk about muscles. So the easiest one of this chapter is the clavicle. The humerus is the next bone, and you can see that I have several things written here. I want you to write those things in, because you're going to come back to this page when we start to talk about the muscles. So the first thing that I want to look at, so this is the front view or an anterior view of the humerus. So we have the greater tubercle and the lesser tubercle. So that means it's on the thumb side when we are in anatomical position, and it is a greater side bump on that thumb side, which would mean the lesser tubercle would be on the opposite, or the medial side. Under the intertubercle groove, I have written there latissimus dorsi. That's one of the muscles of this chapter that we are going to cover. I have the crest of the lesser tubercle, again, teres major, one of the muscles of this chapter. Down towards the bottom, which would be the distal humerus, or towards the elbow, because that would be proximal humerus, or the head of the humerus. All of these little things here, you might look at that and think, wow, how am I going to memorize all those things? Because you're going to break down the terminology. So I have a couple things underlined. Epi, EPI, is upon or above. So if you look at where these are pointing, the lateral and medial epicondyle, it's going to be a bump on the medial or lateral side, and it's going to be higher than the condyle. We have our medial condyle and lateral condyle. So a condyle, whether it is the epicondyle or the condyle, is just a rounded surface. If you start to feel towards your elbow area or your distal humerus, you will be able to feel all of these spots on yourself, and now you will know that all of these little rounded edges actually are for something. There is a muscle attachment that is going to be there. For the posterior view, or the back side, again, we're defining the head of the humerus, the greater tubercle. The deltoid tuberosity is on the shaft of this long bone, and that is going to be where your deltoid is going to insert. And that's going to be the first muscle that we'll cover in this chapter. You won't be able to feel the prominence on the bone, but you will definitely be able to feel where your deltoid ends or inserts at that site. All the way down here on the bottom, I have the olecranon fossa. This is where the ulna bone, which is your pinky side forearm bone, is going to hook into and create your hinge joint or your elbow. So these little things that I have written in there, I encourage you so that when you get done with this chapter, you can come back and remember and view all these little spots. So the clavicle and the humerus, 2 of the 3 bones. So now we're actually going to turn back, and just for an overview, and then we're going to individually talk about all these spots. We're going to look at the top picture on page 49. And again, notice all the things that I have written in here, which are going to mean something by the time we get done with this. I want you to know that every spot on the scapula you need to be able to identify. So we'll start with the acromion, which is, I have written there, trapezius and deltoid. So this is a spot on the very front of your shoulder. You can think of it as a little beak that's protruding out forward, and it's the top one. Right below that is the coracoid process, so it's pointing also to the front. So if you were to feel this area, you could tell the difference between the acromion and the coracoid process. These are on the anterior or the front of your body, even though we think of our scapula as being on the back. We're going to continue along the top. We have the superior notch, which is a notch in our scapula that is made for the blood vessels and the nerves that are going to just lay right on top of there for the brachial plexus. The superior angle is the very top part of the scapula. So if you were to reach back, you can find your superior angle. And I have written there levator scapula, and that is deep to the trapezius. So when we look at just what we are viewing on someone's back, we have the trapezius being the most superficial, but then the levator scapula is also going to be right at that spot. Because we are looking at this view here, so you can see down in here, we're looking at someone, we're going to define the medial border, which is going to be closer to our vertebrae or our spine. And then the opposite is going to be the lateral border, which is coming down out of the axillary area or your armpit area. In between the medial and lateral border, we have the very ending point, the inferior angle. So being down here, that's where your inferior angle is. The next they have here is the subscapular fossa. Because we are looking at the anterior view, so if I was to walk up to you, put my fingers through your rib cage to get to your scapula on the back, that is defined as the subscapular fossa. So that shallow depression for the fossa. All the way up into your axillary area, if we go all the way up that lateral border, we get to a very center spot, the infraglenoid tubercle, which is where one of the heads of the tricep is going to insert. So it's going to be all the way up in here in our axillary area. If we follow that lateral border around, where the head of the humerus meets up with the scapula is the glenoid cavity or fossa, so this little circle part here. And then at the very top of that circle or cavity or fossa, we have the supraglenoid tubercle. So I have written there, it's the bump or the little swelling that's on the top, and then we have the bump or the little swelling that's on the bottom. So this would be, again, where the head of the humerus is coming to meet the scapula. The bottom picture is if you are looking at someone's posterior or their back. And again, we're going to define some of the same spots, but we're going to add a couple in. So we started with the acromion on the top one. The clavicle meets up right here with the acromion to have that acromioclavicular joint. The superior notch where those blood vessels and brachial plexus are coming in. Superior angle, we already talked about, very top. The very bottom is the inferior angle. We have our lateral border, which is going up to our axillary or our armpit area. They have the infraglenoid tubercle, which is the lower bump. The supraglenoid tubercle is at the top. We can't see it in that view. Then we have the medial border, opposite of the lateral border. And what I have written here is rhomboids and serratus anterior, two muscles from this chapter that we'll talk about that take up this medial border. We have three new terms at this view. We have the infraspinous fossa, the supraspinous fossa, and our base camp, the spine of the scapula. So if you were to reach back and find the little fossa or the depression above this base camp, you would feel the supraspinous fossa. Supra is above, so it's above the spine of the scapula. The spine of the scapula goes from the medial border all the way around and makes up that acromion that comes around to the very anterior. Below the spine of the scapula is the infraspinous fossa. So it's the depression below the spine of the scapula. And again, all of these points on the scapula that are on this page, you absolutely need to know them because you are going to be palpating them consistently because of the muscles that are attaching to all of these spots. So all of those spots being extremely important, I do want to point out page 51. And what they're just showing you is ways that you can identify and palpate separately all of these. In class, we will do this, So I need you to be confident with the terms, not only for the muscles, because we need to also palpate all of these areas. So on the top and the bottom of this page, just showing you some different little trails that you can do, and I strongly encourage you to do them. A lot of these spots you're going to be able to feel on yourself, but it's okay to see if you can find a person to palpate so that you can make sure you find all of them. To help with identifying all those spots on our scapula, we are going to go through pages 52 and forward until we get to the very end of these bony landmarks. The spine of the scapula is what is going from the medial border to the lateral border. And I'm going to walk over here and get what I'm hoping will slide over here easily, which would be Mr. Skeleton, just so we can have another view. Ooh, I'm hoping he's going to fit in there. So in red, you can see here the spine of the scapula going from that lateral border to the medial border and the acromion. So making sure that we define that it is oblique angle going from the acromion to the medial border. Please know where that is for sure. The medial border itself goes from the superior angle all the way down to the inferior angle. And again, I have highlighted that that is where the rhomboids are going to attach, and I had that on that previous page. On the next page, on the left, we have the inferior angle. So this is the spot that is at the lower portion of your scapula. So all the way down here, you might be able to reach it on yourself. So that is the bottom angle, which is opposite of the superior angle. Okay, so that's the angle, or the little spot that's on the top. Both of those spots are going to be important for several reasons, not only for the muscles that attach there, but you need to be able to identify them in your palpation skill. At the very bottom, they're talking about a muscle that we haven't even gotten to the muscles, but I want you to, again, circle, highlight something, the term winged scapula. I know with the type of paper that this is, it's a little more challenging to be within the box. But I want you to also write down here that page 86 is the muscle that they're describing here, which is the serratus anterior muscle. So when we talk about winged scapula, I will refer you back to this picture on page 53 to make sure that you have this down pat. When we are observing people in their human habitat, so when they're walking around, I want you to visually see if you can observe anyone's winged scapula, and then immediately you would know that it is from tension in serratus anterior muscle, which is going to help you with how you can perhaps lessen their degree of severity. Continuing with the scapula, page 54 at the top, we have the lateral border. So this is the border that is leading up to your armpit or your axillary area. Right at the very top of that lateral border is the infraglenoid tubercle. So again, you can be referring back to that page that has the scapulas on it, but here's all the little interesting points about it. So when you get all the way up to this spot up in your axillary area, it's the most superior aspect of the lateral border, but when we get to that spot, then we are not only finding that long head of the tricep, but also we've gone through teres minor and deltoid. It will be an easier area for your thumb to fit because of the broadness of your thumb. So I do have that mentioned here on the bottom, because if you just stick your fingers there, it's probably not going to feel so good, but the thumb will be a little more broad in how you approach it. Infraspinous fossa on page 55. So you can see in this picture here that they're identifying that it is a triangle. The infraspinous fossa is below the spine of the scapula. So you can see on his top finger, that's the spine of the scapula. And there is going to be one muscle that covers that entire triangle. Supraspinous fossa is above the spine of the scapula. So now we have the muscle that's below it, or the fossa below it, and the one that's above. And they're just showing you how your thumb is going to fit into this supraspinous fossa. And also, the supraspinous fossa is going to meet up with the acromion and the clavicle. That could be a little important part to remember when a client is talking about decreased range of movement or motion in their shoulder. The top of page 56 for the subscapular fossa. So this is the one, this is the area that I mentioned that if I was to walk up to Mr. Skeleton and put my fingers through his rib cage to get to the anterior surface of his scapula, I can do on Mr. Skeleton, but I can't do that on anybody else because of all of the other things that we have there. But this is on that anterior surface of the scapula, and it is floating or next to the rib cage. Page 57 to see that anterior surface of the scapula. So this is where the spine of the scapula is coming around to meet our acromion, which is going to be the top part of the front of our scapula. And it's meeting up with the clavicle, so that S-shaped bone, our collarbone. And we will, sorry about that. I get too close and it gets a little fuzzy. But the lateral end is slightly higher than the acromion on the clavicle, so you might be able to feel that difference. We're almost done. A couple more points on the bones. Page 58, just to give us a little bit more information about the AC and SC joints. So they are where the articulations are coming together to make those points. So please just highlight, read through those two. I do like how they're showing in this magnified picture here. The SC and the AC joints are really just the two bones coming together. And so it's easy to get them out of whack one way or the other. The top of page 59 for the coracoid process. The way that I remember which beak is on the top is A comes before C in the alphabet, so the acromion is on top. The coracoid process is on the bottom, or that bottom projection beak. Bicep brachii and coracobrachialis are going to be attaching here, and those are also two muscles of this chapter. And then notice what I have, depending on the position of the scapula, you might be able to find this coracoid process in the deltopectoral groove. So this is where the deltoid and the pectoralis major are going to come together. If you know where a bra strap or the side of a tank top sits, it would be right around in that area. We mentioned the deltoid tuberosity when we were looking at the shaft of the humerus. So it's mid-ish somewhere on your humerus. And we have to remember that in anatomical position, our palm is facing forward. So you're going to have to feel that outside spot to find the deltoid. So in this position, it's going to be halfway-ish between the top and the bottom of someone's humerus. And the last page for the bony landmark identification is page 60. But what I want you to focus more on is what they're showing on the bottom. So this is all of the bumps that are at the top of the head of the humerus. And just if you were to palpate your own, which I know you can do, then you can tell the difference between these spots, the greater tubercle, the intertubercle groove, and the lesser tubercle. I have written there the muscles that are going to be important for those spots, but it is easy for you to feel these and be understanding of why these hills and valleys are on that head of the humerus. So that was the bones and the bony landmarks that are important for this chapter. Now we're going to go to the structures that are on top of these bones before we add the muscles onto them. as an overview, I want you to turn to page 100, and this center picture is important for us for several reasons. Number one, you need to be able to identify all of these muscles by the time we're done, but also just knowing what goes on in our axillary area or our armpit area. And notice that all of this area is around the shoulder. So when we talk about having, I don't have as much range of motion, or I have restricted movement, or someone says they can't move their arm in one way or the other, or it hurts when they do something, there's a lot of muscles that are affecting the restriction of that shoulder. And some of these are more accessible in the axillary area, some are not, but it's definitely a tender area. That same picture is what we have on the top of page 101, and you might want to pause by the time we get through this, or you might want to pause it and write all these things down and then listen to how I'm going to describe it all. So this is the same picture that was on that previous page, again identifying the muscles, right? But now we've added in the yellow nerves, the artery, and the vein. So keep in mind, you should know what those two things are when we talk about that. Specifically, I want you to notice that I have the median nerve and that I have CTS written here. That's carpal tunnel syndrome. We're going to talk about that more. But what I want you to think of is this nerve being here, coming out of that brachial plexus. So it's going to be impinged or compressed with carpal tunnel syndrome, but it could be pectoralis minor, could be pectoralis major, could be deltoid, could be coracobrachialis, could be bicep, that are compressing that median nerve, which is potentially going to give us some nerve sensation at our elbow, down to our wrist, or down to our fingers. But all of this comes out of our neck. Remember in chapter 1, we have that view of the brachial plexus, and we looked at how these nerves are coming out of those cervical vertebrae. So you might want to turn back if you need to review that. But some of the things that I wrote about carpal tunnel syndrome is that if the nerve is caught, pinched, stretched, or squeezed in any way, it creates potential symptoms at our elbow, our wrist, or our hand. This could be caused by compression of that nerve from a neck injury. TOS is thoracic outlet syndrome. We can have osteoarthritis. We can have rheumatoid arthritis, or diabetes are some of the common things that happen when this nerve is being pinched. And at the very top there, I have the definition, or I have highlighted there, compression or impingement of that brachial plexus is going to give those sharp, shooting, tingling sensations somewhere down to your elbow, wrist, or your hand. So a lot of information, and knowing how a manual therapist can help someone's compression or impingement has to do with the placement of all of these muscles. At the bottom of page 101, where we have the sternoclavicular joint, what I have highlighted here on the left-hand side is that I want you to notice that the clavicle and the first rib. So our first rib is below or deep to our clavicle before you get to the second rib. So if you were to reach underneath your clavicle and try to find your first rib, you're going to go behind or posterior to your clavicle and kind of curl your fingers around. It's deep. And I want you to be comfortable doing that, because you're going to need to do that on clients in order to access some of the muscles that you need to. So just remembering that information will be very important. The pictures that they have on page 102, looking at some of the ligaments and tendons, and the same information showing some of the bursa and things on 103. I'm not going to ask you any of this information on the chapter test. I have used both of these pages when I have tried to work with clients to get them to understand all of the things that are going on within their shoulder and how some of the ligaments and tendons and all those things are coming together. So that could be helpful for you also. Page 104 is also talking about some different ligaments So again, thinking of what the definition of a ligament is what I want you to make sure you have. We have the coraclavicular ligament and the coracoacromial ligament, and if you take the terms apart, that will tell you exactly where these ligaments are. But just knowing that they are providing stability within that joint, which they're holding together. These are common places for people to have restrictions or to have problems in their shoulder. I call it the pin the tail on the donkey spot. If somebody tells you that they have a pain in their anterior shoulder, if you know where the acromion and the coracoid process are, you can put your fingers right where these ligaments are, and they can say, oh yeah, that's the spot that hurts. It's sort of kind of like magic, but it's really just when those ligaments have been torn or damaged in some way. Also in that area, we have bursa. We talked in chapter 1 about the definition of what bursa is, but just knowing that there is some bursa, or those gel-like sac structures, trying to help smooth out things between all of these little bones that are working in there when we move all of our shoulder. And at the very end here, I have that abduction of the shoulder compresses these bursas or smashes them. So that can be when people have pain or tenderness because of how they're moving their arm. So always trying to get a client to do one pure movement at a time as part of your assessment will be extremely important. We talked about lymph nodes in chapter 1, so they're just showing that you might feel lymph nodes when you're in the axillary area, just being aware that they're there. It also can be a common site that people have had lymph nodes removed when they have had one form of cancer or another. At the top of page 106, we have the brachial artery, and just showing that that is the artery where you could feel someone's heartbeat. But what I have written here on the bottom, which again, don't forget you can pause this. I'm going to scoot this up a little more because I want you to make sure that you have this written out. And I mentioned this on that page that I had the carpal tunnel because this is thoracic outlet syndrome, or that TOS. So a group of problems or symptoms, that's what a syndrome is, that are centered or focused on the neurovascular entrapments that happen somewhere between the neck and the anterior shoulder or the thoracic area, which your thoracic area is your entire rib cage, so it can be anterior, posterior, or lateral. So the tissues are impinged or impaired at one or more places, so it can be on the scalene or the anterior triangle area, or below the clavicle or the rib. It can be when the brachial artery is at risk because of the thoracic outlet syndrome symptoms. So knowing where that brachial artery is where some people can also be experiencing it. Pinched nerves are usually one of the aspects of thoracic outlet syndrome. Mechanical trauma, which is also overused, so keep in mind if you're going to be a manual therapist, we want to be aware of this, can lead to some of the muscle imbalances, which are then going to push on any of those areas possible for thoracic outlet syndrome. And overall, it can include numbness, weakness, tingling, a lifting pain, so all different types of things. So we want to keep in mind when people are experiencing or have been diagnosed, or whether it's self-diagnosis or with a medical professional, that treating it more gentle is going to help it. We also want to be aware that if they are taking any medications to help with the symptoms of thoracic outlet syndrome, we definitely have to have a pressure adjustment due to that. So a lot of information which is a little separate from this, so just a pathology that goes along with that brachial artery, but also it's in the area of anywhere within the shoulder or rib cage that this could be occurring. So that is the bones and the structures that are on top of the bones that we have covered. Now we're going to go back and start to talk about all the different muscles of the chapter And then when we're done with that, we will work on all of the actions together, which I have created little ways to help us try to remember all of those actions. We're going to start on page 67 with the deltoid. So how they have this book laid out, we have the origin, insertion, the actions, and then they also list the N, the nerve. There's only a couple times in this book that I will refer you to looking at this nerve, and I have it highlighted, so don't worry about that. Otherwise, I want you to focus on sort of kind of the origin and insertion, but what you need to make sure is that you know where the deltoid is. So if I say deltoid and you know it's here, that is 90% of everything you need to know. We're going to talk about each origin and insertion site, just so we have all of the terminology, but I promise you if you can just identify that the deltoid is on your upper humerus, that's going to help you with the actions as well. So this bottom picture here, and they have this for every muscle in this book, they have kind of like the black and white, or just where it is, origin, insertion on the bones. So this is the lateral 1/3 of your clavicle, so that outer edge, the acromion, which is that point right on the anterior or the front of our scapula, and going all the way down and including the spine of the scapula. That's the origin, all of that. Insertion is that deltoid tuberosity, that spot on the center of your arm. I want you to notice also that there is anterior, middle, and posterior fibers of the deltoid. So there is a front, middle, and back. In the paragraph, I have that the origin of deltoid, so this is that O here, is identical to the insertion of the trapezius, which that's the next muscle we're going to talk about. So where this muscle starts, trapezius is ending, and that as this all curves around the clavicle and the spine of the scapula, they call it kind of a V shape. I think how the fibers lay is more of a V shape to me. So we have the anterior, middle, and posterior fibers, but we are also, when we turn the page, we'll see another picture which I like a little bit better, that is showing how all those fibers are laying. But I do need you to highlight that all three groups of the humerus have an all-fire action, which is to abduct, so taking your arm out or away. So that's an all-fire action when anterior, middle, and posterior are working. Separately also, the anterior fibers and the posterior fibers are antagonists. So when I move my arm forward, my anterior fibers are making it happen, which means my posterior fibers are fighting it, or it's an antagonistic action. I do want you to know that all these things, all these actions, we are going to talk about at the end, but individually you can see the breakdown of the anterior fibers, the posterior fibers, and then all fibers. It is important to take you through that information, which again I'm going to do at the end because it's going to make more sense, I promise you. But you can see it individually here, and you will with every single muscle. So here I have the question of how or what action would lengthen the anterior fibers, just as a thought process. So if we know that the anterior fibers flex my shoulder, which is bringing it forward, medially rotating the shoulder, so this would be bringing my hand to my belly, and then it also horizontally adducts the shoulder, so I go out to the horizon and I add it to the center. That's what my anterior fibers are going to do. So how would I lengthen them? I would actually be lengthening them when I do the posterior fiber actions. When I do extension, which is bringing my arm back, that's extension of the shoulder, these front muscles are lengthening out. So just as a thought process. The posterior fibers are also going to laterally rotate. So if I put my thumb out to hitchhike, that's lateral rotation. and horizontally abducting. I go out to the horizon and I reach behind me a little more. That's horizontal abduction. So again, all these are going to make more sense at the end, but I want to point out that they're there. I do want you to make note of this all fire action. But now for a little better view of what the fibers look like, that's the picture that I like on the top of page 68. So when you look at that, you can just see how it kind of looks like the frosting on a cupcake or a cake. They're just all like layered in there, all together. They look fabulous that way, and how they all converge down together. This is where we're talking about the antagonistic action of the anterior fibers are antagonistic to the posterior fibers. This gives you a little way that you can know that and figure that out for yourself or feel that. So that's an important little box to look at. That is our deltoid. Next, we're going to go on to trapezius. So as I've highlighted there in the pink on top, trapezius is the most superficial on the upper back and our neck. So if you just reach your hand back, you're definitely going to be touching your trapezius. We will go through the origin and insertion, okay, which is actually on page 69, where you can read all of that out, and I will do that as we look at this. But I want to make sure that you also highlight that the upper and lower fibers are antagonist in elevation and depression of the scapula, which we'll talk about those actions too. So first we're going to look at what is the origin of this big muscle. This is a really big superficial muscle. And then how we want to remember that the insertion of trapezius is the exact same as the origin of deltoid. So one muscle is starting and the other is ending in the exact same spot. For how we are going to look at the origin, I am going to keep it on page 68, and I'll just point to it on here. So first of all, we have a couple spots that we have to identify. So when you look at it right here, and then here, you can see in your book, a little easier than on the screen, but there is an external occipital protuberance, so a bump on the back of your skull where this is coming out. And the nuchal line is what is going side to side from each of that bump. So it goes from medial to lateral on both sides. This is where the origin of trapezius begins, but all of this is origin. See how we're going down here? So we're going to attach to the spinous process of our cervical vertebrae. We have spinous process of C7. We're going to continue down to the spinous process of the thoracic vertebrae, which is the most protruding bump on our posterior vertebrae. All of that is origin. Then, as you can see, these upper, middle, and lower fibers are going to kind of blend and come all the way out to the spine of the scapula, the acromion, and that lateral 1/3 of the clavicle. So the same area as the deltoid. So all of this origin, all the way to insertion. It might be easier to look at this picture also to keep in mind the upper, middle, and lower fibers, and look at how they lay. The upper fibers have to get out to that triangle point. The middle fibers laying towards the top of the scapula, they're just going right out there. But the lower fibers have to go all the way down from the bottom, and then those fibers have to come up to find that point again. So it is easier to look at it in that view, I think, than looking at these lovely words. But I do want to point out, so I want you to highlight what I have here for the upper fibers, middle fibers, and lower fibers. When we talk about actions, again, keep in mind that we have bilateral and unilateral. So both sides, bi means two, or unilateral one side. This one especially we are going to talk about at the end. We just have to keep in mind that we have upper, middle, and lower fibers. But when we talk about this origin, I have here ligamentum nuchae is on page 218. So we're going to skip ahead. It's another chapter, but I think it's important that you see what this ligamentum nuchae is. So it is the top of page 218, ligamentum nuchae. And when you look at the picture here, you can see here is our spinous process. So that's the most protruding spot on the back of a vertebrae. And then we have this red colored stuff, which is our ligamentum nuchae. We are going from the external occipital protuberance, so that bump that I talked about. We have the nuchal line, which goes on each side. And then this connective tissue is laying right on top to kind of protect the back of your neck. So if you reach back to the back of your neck and you feel for this superficial area, it kind of clumps back and forth on the back of your neck. So I encourage you to find that, because this is part of the origin of trapezius. So now if we go back to page 69, we can see that external occipital protuberance. The upper fibers are laying on top of the spinous process. Here's another view of the same thing. It's just really hard to see all of this when we have the muscle laying on top of it. And then remembering that it all comes out to this insertion site out here. The other view on the next page of trapezius is going to help us just with the middle and lower fibers. So we can see the middle fibers here. Think of it as the scapula area. And then the lower fibers, they also have the lower fibers here too. You are probably not going to be able to feel the difference of the direction of these fibers with your palpation, but if you know that they go from here and they have to come out to the shoulder, you can visually see that. And the same when they're going from just right on top of the shoulder blade, and then also when they're coming from the bottom up. So sometimes there's different pictures on different pages that are a little bit easier for us to remember. But we're going to talk about the actions at the very end. I just want you to take in each muscle at this point and the information about it. Page 71 for latissimus dorsi and its best friend forever, teres major. So if you remember that this is the first set of best friends, that will serve you well. So individually, we have latissimus dorsi, and you can see how big and broad it is. Broadest muscle on the back, right? It's very big. Goes from our vertebrae of our thoracic area. It comes across the inferior angle of the scapula and all the way down, including our lumbar vertebrae, and it attaches also to our posterior iliac crest. All of this is your origin. So this white part from our vertebrae, top to bottom, and including the sacrum and that posterior iliac crest. Then if you look at these fibers, they're all going to kind of lay sideways and go a little upward to get to the insertion site. And I have here to see the next page because it makes more sense. So over here we have our origin, so spinous process, thoracic, lumbar, down it includes our posterior iliac crest. It also attaches to the rib cage in the very bottom of our scapula, origin, but it inserts on the front or the anterior aspect of our humerus below the head of the humerus. Here's another view of what that looks like. So now back to page 71 to look at its best friend forever, teres major. So this is going to start at the inferior angle of the scapula along the lateral border, origin here, and then insertion is also to the humerus, but again, we can see it a little bit better on here. So origin, lateral border of the scapula, and then insertion below the head of the humerus on the anterior aspect of the humerus. Back on page 71, I have noted here page 50 and page 50. That is the view of the humerus where I had you write down all those little things next to all the bony prominences. So this is going to show you exactly where that intertubercle groove is in a little easier picture, and the same with the crest of the lesser tubercle. So I encourage you to go back and look at those two pages. When we started, I said that these two are best friends forever, or the first set of our best friends. I do want you to look at this part and understand what this means. So latissimus dorsi and teres major are sometimes called the handcuff muscles because together their actions put us into that arresting position. So if you remember this little ditty, it always helps most people, that my best friend got me in trouble and the police officer major arrested me. That helps me remember that collectively these three actions bring my arms around into that arresting position. So best friends got me arrested. That helps me remember who the best friends are. It was the major, because we are going to have a teres minor, so that's why this works. And then this being the broadest muscle of the back, that helps me remember these two best friends. This box, I want you to highlight to go back and look at later, not right now. I prefer you not to focus in it right now because it might only confuse you because we have other actions of the arm. But I just want you to go back and somewhere towards the end of your review of this chapter, read it and see if you can make it make sense. As far as this right here, I have adduction could lengthen the fibers. I want you to write that down as a thought process, and when we get to the actions or the movements, I want to make sure that you have that written down. And then also at the very top, I want you to know that both of these muscles are deep to trapezius. So two views of these muscles, origin, insertion, and where they are, although they're not showing teres major here, but also on page 73, they have some other ways that you could palpate or feel these muscles. Again, I want you to just figure out where these muscles are located at this point. Page 74, whew, whole lot of highlighting going on there, right? We have our rotator cuff muscles. I do want you to notice here that I have written out SITS because they are known as the sits muscles. That is supraspinatus, infraspinatus, teres minor, and subscapularis. So the sits, you need to know it by this as well. Together, all four of these muscles are stabilizing the glenohumeral joint. So that is where the head of the humerus meets up with the scapula. And they are attaching to the head of the humerus. So they're on the scapula, but they're attaching to the head of the humerus. 3 of them attach on the anterior humerus, and 1 attaches on the posterior head of the humerus. So here in this upper part, I want you to make sure that you have all of this highlighted. So don't forget, you can pause through here. The supraspinatus is located in the supraspinous fossa, so above the spine of the scapula, and attaches to the head of the humerus at the greater tubercle. It works with the deltoid to lift the humerus out away from your body. So this is our first one, supraspinatus. Infraspinatus is our next one, and it is below the spine of the scapula. You can see there's actually 3 individual layers of muscles here, and it is not only deep to the trapezius, but there is also a little bit of it that the deltoid is on top of. So it's below the spine of the scapula, and these 3 areas are our multipinnae fibers that are very thick and are covering this entire lower portion or below the spine of the scapula. Down on the bottom here, we have teres minor. It is smaller than major, which is down here, but it also is on that lateral border. You're not going to be able to feel the difference between where teres major is and teres minor because they kind of blend right together. But again, this one is going to the head of the humerus also, and teres major, which is down here, it's going to be below the head of the humerus. The last one of the 4 rotator cuff muscles is subscapularis. So it's on the anterior surface of the scapula. So if I walked up to you, stuck my finger through your rib cage, you can poke your scapula. This is the one that I'm going to be feeling. Look at how these different multipinnae fibers, so all the different layers of it. But subscapularis is the only one that attaches to a separate spot versus the other 3. So it is going to rotate my humerus differently than these 2 because of that insertion site. When you look at page 75, so here's all the breakdown of origin, insertion for all of them. You do not have to memorize all of this. I want you to know where they're located, supraspinatus, infraspinatus, teres minor, and subscapularis. But the insertion sites are so close, you don't have to memorize that. You do need to know that they go from the scapula to the head of the humerus, and that subscapularis is on that anterior portion, so it is different. But the other thing, we have our next set of best friends, infraspinatus and teres minor. I call them the it muscles. They're best friends. So infraspinatus, teres minor, that's our its. This little spot down here is the major that arrested you, so it works with the other best friend. All of these stabilize the glenohumeral joint. They do not all do rotation. I know they're called the rotator cuff muscles, but this little guy right here, supraspinatus, so above the spine of the scapula, is not involved in rotation. Make sure you know that. That's an important one. And again, at the state level, they like to throw little things like that out to you. So it's on the above the spine of the scapula. It does not do rotation. So very important. Part of that reasoning is if you go back here, look at it goes underneath the spine of the scapula at the acromion. So we cannot do rotation. On page 76 and 77, just some other views of how you could access or learn about some of the different areas of these rotator cuff muscles. This one is definitely one that if you've ever rubbed somebody's shoulders, you've probably done this without even knowing, right in that supraspinous fossa area. And on page 77, again, how we can find teres minor and potentially also the infraspinatus below the spine of the scapula, so different arm movements that we can create. On page 78, some of the same information with how we can palpate that lateral border and try to feel subscapularis. The last page might help you, but no, you do not have to memorize this. So this is the sits muscles, right? So where they're located, where they're inserting. Sometimes placing your finger like this with the thought of on the head of the humerus sometimes has helped people, so it might, so that's why I'm pointing it out, but I'm not going to ask you that view on the chapter test, so it's not like you have to memorize that. What they're showing here on page 80 for how to locate this or make this spot pop out, I would tell you to use caution. Not everyone can do this action. And if they have any restriction in their shoulder at all, this is not going to make them feel good. But it is other ways to try to palpate these areas. So that's why they're showing that. And the same with what's on page 81, just different ways to feel these different areas. This one is important because we talked about the acromion and the coracoid process, so those two points that are pointing forward, acromion on top, coracoid process on the bottom. But it will also help you be able to find where the subscapularis is inserting when you can know that it's below that coracoid process. So that's what I'm showing you there. It just as a thought process, maybe put an asterisk and a year from now come back and go, oh yeah, that's right. Maybe I could find that area a little easier if I identify that bony landmark. On to page 82, for the next two set of muscles, we have rhomboid major and rhomboid minor, which yes, together are called the rhomboids, so you can just add an S to that, but they are two separate muscles that I want you to know about. They also have the major and the minor. So we have teres major and minor, and now we have rhomboid major and minor. So major is inferior, minor is superior. So here is the bigger one, which is actually the major, and then we have the smaller one, the minor. So I have teres major supports teres minor. That also sometimes has helped students in the past keep track of who's where. Origin, if you look down here, whoops, let me scoot that up. You can see that they are originating on the spinous process from C7 all the way down to T1, so cervical and thoracic, and then insertion is almost the entire medial border of the scapula. Not the entire thing, it goes right to the spine of the scapula. So again, that base camp is important to know. So if you go back up, you can see how they're all inserting there. The rhomboids are located between the scapula and the vertebral column. So this is also the common area that people will tell us that, oh, I have so much tension or tightness in between my shoulder blades. So this and that upper thoracic area. They have thin fibers that are deep to the trapezius, but they are laying on top of, or these two muscles are superficial to the erector spinae group of muscles, which we'll get to in chapter 4. So origin and insertion, here and here, we talked about those. As far as the actions, if you write down that rhomboid major and minor are the I don't know muscles, that will help you remember a lot about them. That is elevation of the scapula, so that's why I have next to that I don't know. They're the I don't know muscles. In this box at the bottom, just some interesting information that for us to be aware of all of these lines that they're showing in this picture is the different layers that are moving our scapula. So when people say they have tension in between their shoulder blades or right around in this area, there's muscles that are moving that scapula in every direction. So it's very important for us to be comfortable palpating every single aspect of this scapula. And again, when we do this in class, you are going to see how good that actually feels just to do those bony landmarks or just palpate around that entire scapula. On the top of page 83, which is where we're ending with the rhomboids, I do want you to write this. Rhomboid major is an antagonist to the lower trapezius in depression of the scapula. And then also write page 68. Because, and I'm going to explain it now, but when you write this down and have that page, you're going to be able to see that for the future, because this is really when it's going to matter. What I want you to look at is on page 68 where we're looking at trapezius. So notice that we have the inferior angle of the scapula. So we're going to imagine that this is our medial border. It's under here somewhere. And now we're talking about the medial border with the rhomboids. And the rhomboids are going at an angle like this, Trapezius is going at an upward angle trying to get to that spine of the scapula. So when we look at how the rhomboids lay out in this picture back on page 83, can you imagine that the trapezius fibers are going opposite or a different diagonal on the rhomboids? So when people are moving their scapula, we have muscles that are fighting each other. So that's that antagonistic action between rhomboid major and trapezius, which is also why people can say this is the common area where they are having discomfort or tension or however they're describing their symptoms. On to the bottom of page 83 for levator. Levator scapula is one that I want you to memorize origin and insertion. It is not very often that we will have a muscle that I will tell you to do that. Levator scapula is one of them. The reason being is it's extremely important for your future to know origin and insertion. So look at all the stuff that I have highlighted here, super important. And what we are going to talk about here is what I have here. It's about 2 fingers wide and there's a twist in it. So when you look at this, it's above the spine of the scapula for one end, and it's attaching to my cervical vertebrae on the side for the other end, and right in the center, there's a twist. So it's located along the lateral and posterior sides of the neck. That's that side. The inferior portion is deep to the upper trapezius, but levator goes down the lateral side of the neck, and it comes out from under the trapezius and becomes a little bit superficial right at that twist. The belly, right about at this twist area, is about that 2 fingers wide. The levator scapula attaches to the transverse processes of the cervical vertebrae, so that's showing here, right? That's that side. Those are on the side of our vertebrae. And then they go all the way down to the scapula above the spine of the scapula. The brachial plexus, which is that bundle of nerves, arteries, and veins, come out from underneath the transverse processes of the cervical vertebrae, right where levator is. So now that we have that stuff highlighted, let's look at the other pictures that definitely you need to know about levator. So we'll start with the top picture on page 84. First of all, I want you to look at this lovely submarine sandwich. Trapezius, which we've already talked about. This is not a muscle of this chapter, but they're just indicating there is another muscle on top of it. And then you get to levator. Scalenes are underneath it. We don't get to those until chapter 5, but that lovely submarine sandwich. You might more commonly know this one, sternocleidomastoid muscle. That is on top of all of this submarine. So looking at the origin and insertion. So these are ones that we're talking about, those transverse processes all the way down to above the spine of the scapula to that superior angle. So you can absolutely feel this area all on yourself, but I need to make sure that you know that origin and insertion. That bottom picture is just showing how the trapezius is laying on top of levator, but I will teach you how you can get to levator by moving trapezius. Then we're going to feel levator, and then we're going to get to those posterior scalene that are underneath that. So this is an important visual to take in to make sure that you know for the future. So as I have indicated here, make sure you know origin and insertion. Very important. All of these actions will make more sense at the end. So you can see there's unilateral and bilateral, so one side or both sides. But again, we'll get to that at the very end. It will definitely make more sense. I do want you to look at the pictures on page 85, just because it's showing how trapezius, again, is superficial and levator is a little deeper. Another view of our levator down here on the bottom of the page. But notice that they have turned the head, so that is affecting how all of this tension or tautness is occurring in that levator. I encourage you to become proficient in palpating levator scapula without turning the person's head. It will actually help you greatly in your palpation skills if you don't have to do that. Plus, if you rotate a person's head, you are engaging levator, so there's no way to reduce the tension in it if you have it contracting or firing or engaged. Shoot, that was a big one. All right, serratus anterior is up next on the top of page 86. I want you to look, I've got all this highlighted here. And notice in the picture, it is deep or underneath the scapula. So the serratus anterior is anterior or in front of the scapula, laying on the back of our rib cage or the lateral rib cage. It's oblique fibers, which means they're going at different directions, right? They are going to the medial border of the scapula out to the rib cage. So origin, external surfaces of upper 8 or 9 ribs. So somewhere in this area, all of these, that's our origin. Insertion is to that medial border on the anterior surface of the scapula. So this is underneath the scapula. Now we've already talked about muscles that are on top of the scapula, and then now we add this guy in. So this muscle is unique because it can abduct the scapula, making it an antagonist to the rhomboids. So what that means is serratus anterior is fighting the rhomboids that are on that medial border. And again, when we talk about all the actions, it'll be a little bit easier. But I also want you to notice here that this is the muscle that we talked about with the winged scapula on the bottom of page 53. Way back in the beginning when we were talking about the bones, I told you to make sure that you highlighted that box that was on the bottom of page 53, and this is why. So when this muscle has a lot of tension in it, it pops up that scapula. So that's what we're talking about with that serratus anterior. When we get to abduction of the scapula, it'll make more sense as to why the rhomboids are trying to pull it up and move it, and the serratus wants to hold it down. And just think of all that stickiness that can occur underneath there. And then we have subscapularis on that anterior surface of the scapula as well, also contributing to why someone might have a little less mobility in their scapula. These bottom pictures are just highlighting origin on those rib cage and all the way out to that medial border on the anterior surface. This picture over here is good to see. This is what it looks like. This is where you can palpate it and feel, but there is also, of course, other muscles coming into play. The pictures that they have on page 87, so this top one showing how they're doing that resisted movement to get serratus to pop out. But you also could find the lateral border of the scapula in order to palpate where serratus is. So different ways, and finding that lateral border is always going to be a little easier. On the top of page 88, again showing how serratus is laying in there. If you had someone in a sideline position, you could find the medial border and the lateral border very easily, and then that would also help you identify where serratus anterior is. Skipping this one so that we can move on to the next one. Pectoralis major. So for this muscle, I need you to recognize several things. So first of all, it's a broad, powerful muscle located on the chest or the upper chest area. It has 3 different parts to it. We have the clavicular, sternal, and costal. If it helps for you to think of upper, middle, and lower, that just might set it all in place, but the proper terms here. Then we have that the upper and lower fibers perform opposing actions at the shoulder joint. Because look, there's a twist that occurs, or a little X that occurs. So the clavicular fibers actually attach to the lower part of the humerus, and the costal fibers of those lower fibers are going up a little closer to the head of it.